前インド保健家族福祉省の次官でいらっしゃいましたスジャータ・ラオ先生よりご講演をいただきます。ラオ先生は武見フェローでありまして、世界エイズ結核マラリア対策金、いわゆるグローバルファンド、さらには WHO 等の理事を務め、現在、前インド保健家族省次官として要職を務めておられます。本日はインドにおける Uhc 実現のためのプライマリーケア、高齢者を含む全ての人々のためにと題してご講演をお願いをいたします。ラオ先生、please take your floor.
Namaskar. Thank you so much for having me here this morning. I feel very privileged to be participating in this two-day conference. I have a small presentation on India, taking you over a 70-year journey since we got independence from British in 1947. So I'll run through a few slides of that, what has happened, and then what are we doing today, with some little focus on the elderly. As you can see, the evolution of policy in primary health care from 1946 to 1983 had several steps. I mean, there were 10 different steps on where we are today. So I'll run through the first slide, shows about the first 20 years when we came up with the National Health Policy in 1983. India inherited a wonderful report, a 3-volume report from Sir Joseph Bore, who was appointed by the British to study India's health system. And he, naturally, those days, the focus was on malaria and maternal child health. And he gave us one message, that none to be denied care for want of ability to pay. That has been a vision that we inherited from the British, but unfortunately, we still need to realize that. In 1978, so the first 20 years, of course, we had several problems. India is a large country. We had about 800 kingdoms to be forged into becoming one country. There was famine of 3 million people died on the eastern side. So the independence came with a huge cost. And then we had the partition from Pakistan, which again was a humongous problem with the largest migration of people from one place to another. So with all those problems, the focus in health was largely concentrated on reducing malaria, which was 75 million cases at that time, and we had huge incidence of smallpox and other infectious diseases. So along with setting up primary health care, these were the focus areas. In 1978, by the time we went into Alma Ata Declaration, where health was declared as a human right, and comprehensive primary health care and health care for all by 2000. India was a signatory. By then, we had eradicated smallpox. We had brought down incidence of malaria to 2 million from 75 million, and had a relatively small spread of primary health care, had set up institutions for developing more and creating more number of doctors and nurses and so on. In 79, however, though we were very committed to the Alma Ata Declaration vision, 1979, the Rockefeller Foundation kind of felt that poor countries like India cannot really afford the concept of the comprehensive primary health care envisioned in Alma Ata. And so the focus on high disease control programs was the recipe given to us, but having a high impact on poor people. So 1983, first national health policy was drafted, which again went back to the comprehensive primary healthcare vision of Alma Ata, focusing on communities and a huge engagement with civil society. But in 1993, by that time, the economy had deteriorated so much that we had to mortgage much of our gold to the UK bank. We had to take on the IMF structure adjustment. So this meant in health, no money, drastic reduction in health budgets. Schools were closed, colleges were closed. We were just paying salaries, but there were no drugs, no equipments, no infrastructure development. And the money was available only largely through World Bank funded programs, which were again for the disease control programs such as TB control, blindness control, malaria control, and reproductive child health, the very primary level diseases. but had huge morbidity and impact on poor people. So in 2000, the second national health policy came along, which again reiterated that we need to have a primary healthcare system and a public delivery system focusing on public health services rather than only doing these vertical programs which were focusing on diseases. By this time, from 1993 to 2005, there was a nationwide survey conducted which really showed that because we were neglecting hospital care, we were neglecting the building of primary care and providing of drugs and proper diagnostics, people were getting impoverished. This was a time when studies showed that almost 6% of our population was getting impoverished and pushed below poverty line every year. And a large number were really getting impoverished were from the rural populations. So this again, by that time, in 2005, the result of the surveys had a big, huge impact on the political system. 2004, we got a new government, and they were compelled to address this issue of impoverishment by the people, and they came up with, in 2005. And so the National Rural Health Mission was, to revitalize primary healthcare, was launched by the government with a threefold increase in health budgets. But then in 2009 came along Rockefeller Foundation calling for universal health coverage for all. Now this has become a global agenda. And in 2015 we had the SDGs, which again called for essential care, drugs and vaccines by 2030. So India is now committed to achieving the UHC vision. And the third national health policy came in 2017 to strengthen wellness clinics, again going back to primary care, close to the community. A wellness clinic is located at 5,000 population, and to strategically purchase services from the private sector in order to expand access to universal health coverage. Now, the epidemiological shifts are that, since 2011, 2014, this is the India Health Disease or Burden Study, which IHME and ICMR had collaborated. And this really shows that the communicable disease and maternal, perinatal, and nutritional conditions had reduced to 37. They were about 50% or so in 1990, had reduced by 2011 to 37, and further reduced to 28% in 2014. And the corresponding rise of cardiovascular diseases, COPD, and cancers, and diabetes, and other non-communicable diseases was a very, very important insight that we had to acknowledge in both public policy and as for further investment. Yet, India is 1.3 billion people to begin with, 6,000 dialects, 14 national languages, huge country with wide disparities. So there's just no way we can just think of one universal health coverage for the whole country as a whole. So here you find the massive diversity in the epidemiological situation and the disease burden between the North and the South. So you find these are the North Indian states which account for almost 600 million population, and they account for 58% of the child deaths, 70% of the infant deaths, and under 5 mortality, and 80% of the maternal mortality. Kerala, this is probably as big as Japan maybe, and they have a longevity of life highest in the country of 74 years, and Assam has 62 years. So there's 11 to 12 years difference between the lowest and the highest in the same country. So that's a kind of variations and diversities that they are. So we cannot have one size fit all prescription. This is again the interregional differentials of disease burden of mortality 2017. And as you can see, the northern with 600 million population, southern and Maharashtra included, south and west has about 665 million population, and this is the India figure. So under you see that communicable diseases, 35% in the north, 20 only in the south. So whatever we say in India, we have to have a different prescription for the southern states, which have a higher burden of non-communicable diseases, which is 68, as compared to communicable diseases, where in the north, we have to do the opposite and spend more time. But that does not mean that non-communicable diseases do not matter. They do, but they also, we have to make the epidemiological transition. In fact, the ratio between, how do you go back? Anyway, it doesn't matter. The epidemiological transition ratio in Kerala was 0.16. In Bihar, a northern state, is 0.72. So that is the kind of variation between the north and the south. So in the National Rural Health National Rural Health Mission that was launched in 2005 to 17, these were the broad components that we had. Reproductive child health was a very important component because we had very high maternal mortality. And so these were the components. And today we have immunization for 14 diseases. We cover 30 million pregnant women and 26 million children every year. And we protect the children for 14 diseases. And then we have TB, leprosy, national vector-borne diseases, and integrated disease control program as a communicable disease pool. Then we have funding for non-communicable diseases and infrastructure maintenance. And in the health system strengthening, broadly, over 10 years, we've been able to achieve some significant gains. One was that we've been able to have 1 million social health activists, that is a community of 1,000 people, has a trained health worker to work, she belongs to the village, she's been trained, and she really helps the people access the health system, which has had a huge impact on people getting access to our services. And about 250,000 people have been appointed medical and non-medical personnel in the last 10 years, which in the formal system of recruitment would have taken us something like 30 years. Community support has been one of the major pillars, and we have 600,000 villages. Everywhere there is a health sanitation committee, and we have patient welfare societies. So there is some step taken to recognize and acknowledge that you need to involve communities in your health work. It is still a step in progress. And in infrastructure, again, facilities were strengthened somewhat. The importance of threefold increase in budgets and this kind of high political priority did help in reductions, both under 5 mortality and the maternal mortality. Compared to global figures, India was able to achieve a 20 to 50% faster decline. Infant mortality has also reduced somewhat from 80 to 34. And HIV/AIDS incidence in India was the highest in the world. We reduced by 66% during this decade as compared to the rest of the countries, which were much, much lower. And it's a very important, significant data because India is a very conservative country. We have a lot of issues talking about sex and safe sex, advertising it or talking about it openly. And yet, we were able to promote the condom, promote safe sex among gay populations and sex workers and so on, who are criminalized groups in India still, and yet achieve the incidence, reduction incidence, which is really very important and very significant. Longevity of lives also, we've been able to, from 1990 to now, about 11 years has been added. But the challenges are huge. In all these efforts that India has been doing with the public system and disease control, the biggest challenge that India faces today is a huge extent of private sector, which is 3 times more costly than public hospitals. It's growing very rapidly at 17% a year. It is focused largely in urban areas and in tertiary and secondary care space. In the primary sector, it's very difficult to find a government doctor, except in the government facilities, a graduate doctor. Most of them are run by what we call them quacks because they're unqualified medical doctors and or solo practitioners, a few of them here and there scattered. But largely, there's such a huge shortage of human resources in India that whatever qualified doctors and personnel that we have tend to be in small nursing homes or in hospitals giving secondary and tertiary care, and also primary health care is administered in those areas. So it is a very costly proposition because it's unregulated, there's no control on prices, and therefore we have almost 4 to 6% of our people getting impoverished on account of health. And public spending is shamefully low. It still continues to be 1 to 1.15% of GDP. That has been the case all these years, at times of good growth and at times of bad growth. To expand access and reduce impoverishment, which became an emerging issue, 20 states, we are a federal country, so the central government is one thing, and then the states have their own responsibilities. About 20 states have introduced their own government-sponsored health insurance programs, which really means that they pay the premium. They either administer themselves through an independent trust, or they pay the premium to an insurance agency to cover all the families below poverty line on a floater basis. So a family is covered, and sum assured is indicated. So as on today, under this scheme, under the government employees health insurance programs, private insurance, all put together, about 25 to 30% of the population has some sort of an insurance and social security. But, and of them, 1/4 is in the private commercial arm. The rest of the 75% are covered by government under 2 or 3 social health insurance programs, as well as this government-sponsored program for the below poverty line families. But the health system is very fragmented. There is no gatekeeping. There are no pathways to show how patients must go from primary to secondary to tertiary. With the result, there is such a, over the years of neglecting primary care in India, today culturally people want to go only to, they have faith only in hospitals. They want more diagnostics. They want to go to a private doctor, and they're not interested in doing preventive or doing any primary care behavior changes or lifestyle modifications, and they're not managing risk. This is a popular perception to which the political system also does seem to respond to, because the investment is increasingly geared more towards hospital care rather than primary care and risk reduction. So we have a universal health coverage concept in India, in the sense that government does provide universal access, and it is pretty much implemented all through. I mean, the rich may not take avail of the government expending, and go to their own private hospitals, but they're eligible, and if they went to a government hospital, they would get these diagnoses and treatment for all infectious diseases in all public health facilities free of cost. We have the largest cash transfer scheme for pregnant women, where we give about $30 for her as an incentive to come and deliver in the public hospitals. And the states have also introduced a sum of 2,000 to 4,000 sum assured to the people, where they have co-opted and contracted private hospitals which provide these secondary care services, and majority, of course, are in the private sector. Now, recently, as I speak, about 10 days ago, the budget, in the recent budget, the national government has now increased coverage for 40% of the population, which means not only those who are below poverty line, but slightly above poverty line, to cover them with, which comes to about 100 million families in the country, with a $9,000 per family coverage per year. Now, this has become very controversial, and therefore, as I said, because largely the whole concept of UHC, ever since it was announced, is seen more and more as providing access to hospitals for procedures and surgeries and medical and non-medical reasons, but as inpatient treatment, whole effort of outpatient care, drugs, diagnostics is not included in the insurance, and this is one policy that is being critiqued very intensively, because it addresses only 30% of the out-of-pocket expenditure issues, and 70% still continues to be for drugs and diagnostics. With the result, all these insurance programs have not really helped in reducing out-of-pocket expenditures or catastrophic expenditures. So, importance of primary care, you all know better than me how important it is, how effective it can be as a long-term measure, and how cost-saving it can be. And therefore, India too is trying to have a mid-level provider, something like what the previous speaker had talked about for doing community care. These are the services that broadly would say that we should be providing in a primary healthcare system. Unfortunately, 15% of these services are today being provided due to acute underfunding and lack of adequate resources. Okay, the next one is a program for elderly. This was announced for the first time in 2010. We don't really have a very fully worked out program for the elderly. They constitute about 8% of our population. As on today, we have 100 million elderly above the age of 60. They're likely to reach to 324 by 2050. And the 3/4 of them live in rural areas, they're illiterate, they're highly dependent on their families. 10% of them are bedridden, require home nursing. They suffer from both non-communicable and communicable diseases, and family breakdown, social isolation, with the migration of young people going away for employment purposes to the urban areas. The lot of the primary care, a lot of the health needs of the elderly, who particularly living in rural areas, is really quite severe. They face physical and psychological abuse, and therefore it is estimated that of the large number of farmer suicides that take place in our country, 25 to 30% are among the elderly, only because they are not able to cope with the chronic diseases that they suffer from, which adds on to already an indebted situation of the farmers. So geriatric care has been sadly and badly neglected in India. Finishing. And then this is the delivery system that we have in India. And therefore, the idea now is to really have community-based and home nursing and so on for the geriatric, for the elderly and for communicable diseases. So there is a population-level screening going on as we speak in many parts of the country. Just one more slide. And there, as you can see, a unique card is being given. Now, technology and computerization is very helpful. All the above 30 are being screened then for all these risk factors. Then they're sent for diagnosis and treatment, and the pharmacy gives the drugs. And this is now trying to be taken to the lowest community level and increase access, focus being diabetes and hypertension and elderly care. Conclusion is, focus is shifting towards NCDs, geriatric care and mental health, though we still have a huge burden of communicable disease that we cannot ignore. The 4 primary pillars of primary care are aligning incentives. How do we incentivize our providers? How can we have more proactive and preventive healthcare through active case finding, like the population health screening that is being done, active case finding and a family approach? And how can we have appropriate level of care being dispensed at different centers of healthcare? And at whatever be the situation, how can we have a sustainable system which is at a low cost? I think this is my last slide. For achieving the goals, these are the 6 issues that we need to be taking focus on. Health has to become a political priority. In fact, I wish the government, instead of borrowing the speed train from Japan, had taken the medical system of Japan and brought it to India. I still feel there's a huge scope for collaboration. Build a health system on the foundation of primary health care, which is extremely important for having a cost-effective, sustainable system. And how do we get, this is our biggest problem, and considering I'm here in the JMA, how do you help our doctors to become more compassionate, less focused on commercial concerns? There's too much of that in India. Profit maximization guides our medical fraternity much more than physician care. How do we change that value system is a huge debate and a huge concern for Indians. And then, of course, we have a regulatory environment that we need to bring in to get that kind of a value chain introduced in India. Thank you so much for giving me this opportunity.
ラオ先生、ありがとうございました。